Welcome to Pediatric Grand Rounds. Today we're happy to have Dr. Brown visiting from the Carilion New River Valley area. We've been referring patients to him for many, many years, but this is the first time we've actually met him. Dr. Brown trained at University of Illinois, Champaign-Urbana, and the Baylor College of Medicine in Physical Medicine and Rehab. He has been with the Carilion family since 2002 and specializes in outpatient rehab, spinal cord injury, wound care, and electrodiagnostics. Please welcome Dr. Brown.
Thank you. You guys actually awake? Yep. There's morning people and night people, and about half and half. You guess who writes the rules? Anyway, thanks for inviting me to come. I'm a rehabilitation doctor. I trained in Houston, Texas, where I was privileged to work at Texas Children's Hospital for a couple of locations, and I worked with Maureen Nelson, who's now the principal author of the rehab textbook. I'm delighted to talk to you today about spasticity and cerebral palsy, and I certainly welcome you to ask any questions along the way, and we'll have a quiz at the end, so please pay attention. So, any thoughts on what this boy has? What anatomic diagnosis he might have for cerebral palsy? I see he's got splints on. He's got, and his hands look pretty good. I would say he's probably spastic diplegia. So there's lots of different definitions for cerebral palsy out there. I don't like long definitions. They get, like in DSM-5, they get to be like half a page long. It doesn't make sense to me to put that all together. But there are some salient features in all the definitions of cerebral palsy. Number one, it's permanent, it's from around birth, and it doesn't get worse. So one of the key things I want you folks to think about is if you have a child with cerebral palsy or has been diagnosed with that, and they start losing ground, you need to rethink your diagnosis because you might be dealing with something much more sinister. Dr. William John Little, back in 1843, who was a member of the Orthopaedic Surgeons in England, and he established the Orthopaedic Hospital in England, was the first person to describe cerebral palsy. Oh, can you hear me? Can you guys hear me? I should have asked earlier, sorry. If your mic is on. Oh, okay. There you go.
Now can you hear me? Oh, I can hear you. So Dr. Little actually had polio, and he was very interested in orthopedic problems of childhood, and that's where he got his interest and first started working on cerebral palsy. He coined the term cerebral paresis. By the way, when do you think cerebral palsy was first recognized by any physician-type person? Hippocrates. Hippocrates in the 5th century actually wrote about cerebral palsy briefly. Sigmund Freud, who was actually a neurologist, I suppose you folks know, also described cerebral palsy as symptoms of deeper-lying influences on the immature brain back in 1893. These are 50 years apart, 20 years before and 30 years after the Civil War. So there's different classification systems for cerebral palsy. There's the one that I use the most is the anatomic, which would be diplegia, meaning primarily affecting the legs, although if you did very careful studies of their dexterity, you would discover that they also have some slight dexterity problems, but not bad. They tend to be able to use their hands functionally. Quadriplegics tend to have all 4 limbs involved. Hemiplegics are just like a stroke, only one side of the body, and then triplegic is probably a mixture of diplegic and hemiplegic. And then there's the spastic type, which is most of the kids that we see. Spastic, and I'm going to define spasticity here in a minute. Much less commonly, we see the dyskinetics, like the athetoid type. I don't like seeing I like seeing the hypotonics, but the hypotonics are more difficult because these are kids that usually have the hardest time getting to their developmental milestones. And then, of course, there's always mixed. Every kid with cerebral palsy is different from every other kid with cerebral palsy. They all have unique issues. They all have unique problems. And we always try to think of them as a separate individual every time. There are other classification systems. Palsy back in 1997 developed the gross motor classification system, which is 5 steps. Do you guys use the gross motor scale? Have you ever used it or seen it? It's Dr. Palsy was a physical therapist, and he described 5 steps of the scale, where 1 is almost normal. They can run, they can jump, but they have a little bit of decreased dexterity or fine motor skills, and all the way down to level 5, which is a child that cannot propel or mobilize themselves through their environment. Just to give you an example, level 3 is a child that usually sits with support by 2 and is usually walking with a device by the age of 12. These are not mutually exclusive scales. We can actually use them together. We can describe an anatomic type diagnosis, and we can also describe a gross motor scale. There are other scales as well. There's a manipulation scale, there's an oral motor scale, and they're working on a gastric scale. I'm not sure if I'm saying that right. Gastric. So spasticity and tone are 2 terms that we throw around a lot in rehabilitation medicine. They're not exactly the same thing. Tone is a resistance to range of motion, where spasticity is a velocity-dependent change in that tone. So if I move, for example, if a child has flexion spasticity of their arm with a tight bicep, and I range them slowly, I can get through their range of motion, but if I go quickly, it'll stop and block me. So how common is cerebral palsy? Is this a rare condition? I would call it extremely common. Some authors say as many as 5 per 1,000 live births. So is the incidence going up or going down? It's going up. Any idea why? More kids are born now with cerebral palsy than ever before. Why?
Advancements in preterm delivery.
Children are living that used to die before. Right. So advancements in technology in the NICU and also with preterm labor and so forth have allowed children to live that may not have lived 20 years ago. So the incidence is going up. It actually is quite common. Most of these kids will walk, and most of these kids will have essentially normal intelligence. Now, these are called risk factors, but I prefer to call them associations because any child with any one of these conditions or situations will not have cerebral palsy. But if they have many of these malpresentation, post-maturity, low APGARs, if they have many of these, they often do. But the main risk factor is really low birth weight. And that, of course, it goes hand in hand with prematurity. We also found very frequently in these children, usually about 80 to 90% of them will have changes in their scans of their brain, and so they have paraventricular leukomalacia. So do you guys see this? Whoop, sorry. So what's going on in this area? So these are white matter areas around the ventricles. Do you guys remember your sensory homunculus? Your motor homunculus? Sorry. This is the area closest to the legs. So cerebral palsy does have a propensity for the lower extremity. In fact, I would say probably about 90% of the kids we see with CP do have tight gastrocs. The gastrocs are a very common muscle that we'll even BOTOX or we'll focus on with our splinting. There's many other problems that these children have. Oculomotor, so they have difficulty with saccadic movements in their eyes. They do have decreased visual acuity. We have some children, spastic quadriplegics, who are cortically blind. Oral motor skills are lacking. They have difficulty with bolus formation and with swallowing. And then there's a malnutrition issue with these children. Now, do you think these are related? Yeah. If you can't eat, how can you be nourished? That's why what I like about working here is that our gastroenterology folks are aggressive about putting tubes in these kids, especially if they're underweight. I have picked up some kids who were not treated until later, and they were grossly underweight, and then they developed decubitus ulcers and so forth. Aspiration, of course, would also be related to this as well. How many kids with cerebral palsy have constipation? Practically. Thank you. The book says 80 to 90%, but I think practically all of them have constipation. And constipation, by the way, hurts, and it worsens spasticity. And it seems like at least half the time I bring this up with the parents, I bet he's constipated. They say, he's not constipated. He has bowel movements all the time. And then we do x-rays of their hips, and they're loaded with stool. And this is a very common problem. Bladder incontinence, fecal incontinence, cognitive impairments about 30% of the time. Somewhere between 20 and 30% will develop seizure disorders, and somewhere around 10 to 15% will develop hearing difficulties. So what's the major impediment to voluntary movement in children with cerebral palsy? That's a major impediment. The inability to separate out individual movements. So if you've ever worked with stroke patients, which I don't suppose you're all pediatricians here, you probably don't see many strokes, but when you start developing motor movement, you do not have initially the ability to isolate individual joints, like the wrist, fingers, elbow as an example. What you have is synergy patterns, which is you might be able to gross flex or gross extend, but you can't isolate individual movements. Well, guess what? We need to be able to isolate joints in order to function. For example, when we go to swing our leg while walking, we flex our foot while we're extending our knee and hip. But if you have an extension synergy pattern, you're going to extend them all, and therefore the only way you can get your foot around is by circumducting or putting a brace on. Anatomic diagnosis? Hear me, please. So how do we evaluate these children with regard to their movement disorder? Well, I remember from my pediatrics training in medical school that observation was key. And sure enough, in our clinic, I spend a lot of time watching the kid while the therapist that works with me, Laura Alexander, does the actual range of motion measurements, and I'm asking questions of the mom. The whole time I'm watching the kid to see how they move, to see how they interact, to see their eye contact, and also their intelligence. Obviously, you have to know the developmental stages with, for example, the Denver or the Gazelle. What do you folks use here for your developmental stages? Do you have any preference here? Denver? I don't know. Denver seems easier. The problem with the Gazelle is that it is a little bit advanced compared to most kids because it was Gazelle's kids, and apparently they were pretty advanced kids. I mentioned synergy patterns before, and then abnormal or persistent reflexes. So how important are sensory deficits? Extremely. Adequate balance, coordination, head and trunk control rely primarily on sensory input and integration in order to use them. Of course, the problem is that it's very hard to measure sensory deficits. Sometimes you have to almost go on what the parents tell you, whether or not, like for example, if they hurt themselves and not realize that they got hurt, things like that. Even children with minimal involvement can exhibit apraxia when performing high-level motor activities, and these are sometimes things that are hard to tease out until they get into therapy. So what kind of modalities are found to be disordered? These are just some of them, but these are the ones most often mentioned. Two-point discrimination does have the advantages that we can measure it. By the way, where is our best two-point discrimination in our bodies? Children, adults, everybody. Lower lip. Our lower lip has 2 millimeter, normally a 2 millimeter two-point discrimination. Where's our worst two-point discrimination? Our back, 2 centimeters. Diagnosis is not something that I normally measure or even test, but it's the ability to determine what something is based upon its feel, its shape, without looking at it. And then proprioception. And I don't want to blow the quiz, but how important is proprioception? Very. So when we're observing children, we like to see how they move around. Kids are little efficiency machines. In fact, all of us are efficiency machines. When you came here today, you didn't walk around the building 3 times, park in the farthest spot, and call it the wrong elevator. You know, the farthest elevator. You came, you parked in the closest spot, you walked straight to where you needed to go, straight to the closest elevator, and came straight up here. You do it without thinking. That's the way our brain works. We're constantly maximizing efficiency in how we perform our activities through the day. If a child cannot crawl, then they'll find some other way to get from point A to point B because they want to get around. Movement is how they explore their world and how they learn back in the early days. So if it's easier for them to roll somewhere to get to where they need to go, to do what they need to do, they're going to roll. They just do whatever is easiest for them. Combat crawling, I'm assuming you've seen, of course, with lower extremity spasticity. Sometimes it's used for them just to crawl with the strength of their arms. We also look for W sitting, which is we don't like because it's bad for their hips. Bunny hopping, I don't see that often. And the hand preference before 1 year of age. A child should not have preference of a hand before 1 year of age. And then scissoring. So this is probably combat crawling, bunny hopping, and scissoring. Why is scissoring bad? What happens if you don't fix it? Hip dislocation. Fixing, guarding, extensor posturing are other things that we look for. So why are these things bad? Why is it bad to have a persistent reflex? Wasted energy. Okay. So imagine I'm crawling. Should I get down on the floor and crawl? I did for my wife. She thought it was kind of stupid. So if I'm crawling along the floor and I turn my head to look at my brother or sister and I go into an asymmetric tonic neck, how am I going to keep crawling? Right? If it's a persistent, obligatory reflex, I can't crawl if my asymmetric tonic neck is taking over every time I turn my head. So obviously, these are things that are not good for function. Symmetric tonic neck, tonic labyrinthine, all of these, if the reflex takes over your body while you're trying to use your body, obviously you're not able to do what you need to do. So you can have abnormal reflexes like persistent palmar grasp, planar grasp, and so forth, but if they're obligatory, they're always abnormal. So here's some pearls for you. Usually, if a child is going to walk, it's usually going to be achieved by age 7. And typically, the hemiplegic kids and the ataxic kids walk earlier, and hypotonic kids rarely walk. So why do hypotonic kids have such a problem with walking and sitting? Trunk control. If you can't control your trunk, if you can't control your head and your neck, you can't use your arms. If you can't use your arms and legs, you can't use your hands and your feet. If you're sitting by 2, you will eventually walk. If you're not sitting by 4, usually you won't. Most eventually ambulators will have fewer than 3 of the abnormal reflexes by 18 months of age. So how important is walking? You know, some people have really been out of shape when I say this, but I say, you know, walking, yeah, it's important, but it's not the most important thing. Many studies have been done asking people who have disabilities, what's the most important thing to you, and what do they say? Almost always, use of my hands. Hands. So walking, we like to get kids to walk or at least stand because it helps promote normal hip development. But, you know, in modern America, as an adult, you don't have to walk. Thanks to the American Disabilities Act of 1992 by George H.W. Bush and 1994 by Bill Clinton, all sidewalks have to be wheelchair accessible in areas where there's enough population to justify it. All companies that have more than 15 employees have to make reasonable accommodations for all their employees. So America, one thing I have to say I'm proud of is working aggressively to allow all of our citizens to be able to function in our society. But walking does have some advantages, of course. Obviously, it puts you at eye level with your peers, enables you to mobilize without a device, and it does provide exercise. It turns out, though, pushing a wheelchair on level surfaces actually spends about the same amount of energy as walking. Cortical thumbing. Why is cortical thumbing bad? Why is that a problem? How can you use your hand if your thumb's stuck in your palm? Right? You can't grasp. Kids, when they first, as you know, when they first start grasping, that's palmar grasp. Well, if their thumb is in their hand, they can't grasp. Also, what's the most important digit? The thumb. Your thumb, all by itself, functionally speaking, is more important than all your other fingers combined. And of course, pronation spasticity is a problem if you're not able to supinate. And we see a lot of this in our clinic. All right. Dr. DeLuca here? Good. Stephanie DeLuca is a very prominent researcher in the world in constraint therapy. There is nothing, absolutely nothing, that I can do or the therapists that work with me that they can do that's anywhere near as effective as constraint therapy for hemiplegia. Nowhere near. Now, there are some restrictions. You have to be able to have some use of your, it's for hemiplegia, hemiplegia only. It's for, that's usually my mom when I get the duck sound. It requires some use of the involved arm, and the parents have to be able to get the child to therapy for a very intense period of time, usually about 4 weeks. Dr. DeLuca and I had a conversation about 2 weeks ago when I was getting ready for this talk, and she's telling me that some friends of hers, I think out of Australia, are soon to be publishing data that proves, or at least strongly suggests, that when you put a child through constraint therapy, you are actually upregulating stem cells in their brain. Now think about it. You're putting a cast on a kid, you're putting them through therapy. You're not injecting anything in the brain, but you're upregulating their stem cells. It's like stem cell therapy for a hemiplegic kid without having to inject stem cells. So the typical scenario is a cast is applied, a whole arm cast, including the fingers, is applied to the unaffected arm, and they're put in intense therapy, typically 6 hours a day for 4 weeks. And these children make huge improvements. Huge. I have a statistic in here somewhere. In adult stroke patients, we don't have mapping studies in children yet, but it's coming. But in adult stroke patients, which of course adults are not near as good at developing improving after a stroke as a child is, or hemiplegia, they found that if they map them since the motor cortex, the reactive motor cortex, after 2 weeks of constraint therapy, they double the size of the reactive motor cortex in their brain. This is a huge, huge thing, and this is going to be where the primary treatment for hemiplegia is going to be going forward. So here's some pictures of some therapists working with children doing different tasks. As you can see, the cast covers the entire arm all the way down, including the fingers, and then lots and lots and lots of therapy over a relatively short period of time. This is graphic data showing when they do the therapy, they make this much functional gain, they take a couple of weeks break, they lose some ground, but they don't go back to where they started. They do this constraint therapy again, make more ground, and so on and so forth. This is an extremely effective method to improve hemiplegia.
So is this interrupted therapy?
In that study they did. Yeah, in that study they did it for 2 weeks, and they didn't do it for 2 weeks, and they did it for 2 weeks, and so forth. It turns out, and this is actually from Novak out of Australia, who's also a constraint therapy researcher, that a lot of the things that we've been doing since the beginning of time, well, 1950s and 40s, sorry, regarding therapy for children actually don't work that well. The neurodevelopmental therapy is a red light, meaning it's not even been proven to be effective, which freaks out the therapists I work with because that's what they're trained in. Things that we do in our clinic, including BOTOX injections, OT has been shown to be effective. Constraint therapy has a huge benefit. So what's some objectives of managing spasticity? Well, we want to decrease complications. I mentioned before, if we allow kids' hip to dislocate and they end up having surgery later, when we could have made it better by Botoxing their adductor muscles or giving them antispasticity medications, obviously that's a good thing. Because every time a kid goes to surgery, there's all those risks. They lose usually about a motor grade of strength, and then there's a long recovery period. Obviously, we want to give them new skills so they can make developmental improvement. We also, this is a golden opportunity to educate the parents because we want them to stretch, stretch, stretch. Stretching all by itself is probably one of the single most important things you can do for a tight joint or a spastic joint, and getting parent buy-in is huge, as you can imagine. We want to improve their mobility and decrease their skeletal deformity. So some general principles about spasticity. I'm kind of making a little bit of a segue into spasticity because it kind of goes hand in hand with cerebral palsy. Number one, not all spasticity is bad. there are children who use their spasticity to function. Usually where I see it is when they want to transfer from their wheelchair to their bed or wheelchair to the toilet, they'll actually trigger an extension spasm in their legs just so they can transfer. So I don't want to take away their skills. Another thing, too, if I get real aggressive with oral medications and I knock out their trunk and head control, I'm not doing them any good. I'm making them worse. Spasticity is usually worse with anything that would otherwise cause pain or discomfort. So constipation, urinary tract infections, wounds, ingrown toenail, improper seating or braces, kidney stones, bladder stones, pressure on their skin. And, of course, back in the older days, and not even that old, we used to do a lot more ablative neurosurgery than we do now. Dorsal rhizotomy still has a place, but most of the other ablative neurosurgical techniques for cerebral palsy have pretty much fallen out of favor. So here's all the things that we do with the help of course, Dr. Zielinski and the therapists that I work with in our clinic. We use all of these things in varying degrees for spasticity management. Therapy is probably the single most important adjunctive therapy treatment for spasticity and cerebral palsy because it has many different roles. For example, they positioning, feeding, providing range of motion, and education of the parents. And they also discuss with us, the physicians. So they're like, therapists are trained observers, and I hope that you folks have talked with your therapists or some of your patients. You'd be amazed at how much information you can get out of them. It's the most powerful adjunct to essentially all other spasticity treatments. Notice I used adjunct. It works with other things. And it is done in schools. The problem with school-based therapy is that it has to be a school-based activity. So, for example, if little Jill needs to get to class on the second floor, the therapist may teach her how to walk upstairs, but only because it helps her get to class. So one problem is we often can't do therapy for other things that aren't directly necessarily related to school. The advantages of therapy is it's the least invasive and it's safe, and that educational role is truly the most powerful in the world of therapy, and of course the feedback with the physician. But it's expensive and it's very time consuming. When I looked at what therapists were billing, I found out they're billing more than I do, which is high. Casting and serial casting, we put a child in position, functional position to relieve the contracture, and then we apply the cast. Neutral warmth, which is just the heat from your body, aids in stretching the collagen. We know that collagen stretches a lot better when it's warmer. And the longer you stretch, the more effective the stretch is. But you have to have a therapist who has training in this. Not every therapist can do casting. Serial casting is applying a cast for a week. I'm sorry, let me start from the beginning. So the therapist stretches, let's just use the example of the elbow. If the therapist extends the elbow, takes it to the end range of motion, applies the cast with lots of padding, brings the child back in a week, takes off the cast, takes up another couple degrees range of motion, reapplies the cast, waits another week, comes back, takes the cast off, extends the range of motion, and casts again. And with the help of medications and or BOTOX, this can be a very effective way to relieve contracture. And we do that here in our clinic. Yes?
Is there an age at which you should do it by, or it doesn't really help?
No, I think it works for anybody. Yeah. What age? At what age? We don't have an age limit. We will cast just about anybody. So serial casting is not as expensive as other treatments, and it is quite effective. And of course, it's a lot harder to get a cast off than a brace off. Although we have some little Houdinis in our clinic who have gotten very good at taking off their casts, and so obviously we have to find other ways to keep them from doing that. It does work better. It works better for certain joints. You can't really cast the shoulder or the hip, and you can get skin breakdown. It can hurt, and as I mentioned before, it does require special training. Bracing is the application of a thermoplastic material, which means it's usually a plastic that can be heated at a high temperature, typically 1,500 degrees, and formed around a mold of the child's foot, for example, to relieve contracture, promote function, and to protect the joint. And we do a lot of bracing, working very well with our orthotic partners in our area. Here, Virginia Prosthetics and Rehab Excel, which are nearby. Well, Virginia Prosthetics is up by the airport, but Rehab Excel is just down from the Jefferson building. Typically, bracing is done in a sequential fashion, so if a child's unable to walk but they can stand in a stander, we'll give them a solid ankle AFO, and then when they start walking, we'll put them in articulating ankles. And nowadays we're using, I'm going to show you some pictures of what we're doing with Laura in our clinic. Advantages of bracing, they can be used on joints not easily casted. It's less likely to break down skin. That is probably true. And they can be easily removed so you can inspect the skin. And really, you should be taking your brace off at least once a day anyway. Lots of our kids like all kinds of designs. Like we had a girl last week who has pirates or skull and crossbones and things on her cast, which I thought was kind of interesting. More definitive than casting, it promotes function much better than casting and can be made with tone-reducing features. The most common one we use is we put a bump at the metatarsal heads, which actually, by way of the spinal cord, reduces tone at the knee and the hip. Disadvantages, you have to have a certified orthotist to make these things, and not all orthotists are the same. Some are very, very good, and some are not quite so good. And it is expensive, typically at least $700 and up for a cast. And, of course, as the child grows, you have to make a new cast. Noncompliance is an issue, so you have to have parental buy-in. A lot of these kids just do not like wearing the braces, and so the parents have to be a parent and, strongly encourage the child to wear their braces. There's many different types of braces available, and this is kind of just a laundry list. I've got some pictures here. So as I mentioned, the solid ankle is what we usually start with. Again, this would be for a child typically who's not ambulatory. And then as they get more functional, we might put them in an articulating ankle. A floor reactive AFO applies pressure to the top part of the tibia, and this is used for children, for example, with quad weakness because it helps stabilize their knee. The method that we use in our clinic is Elaine Owens method, and this is based out of a researcher out of England, where instead of forcing the child's foot, let's say this child, for example, has a 5-degree plantar flexion contracture. If we force her into a brace, we might get skin breakdown, we'll have pain, and it may actually slow down her ability to mobilize in her environment. So the Elaine Owens method is to bring the floor up to the child, put in an adjustable but solid ankle, and then we use the knee to stretch the gastroc. And these kids will take off. Very frequently, as soon as they get the braces on, they're off. It's a lot more functional position. Probably the most important part of this is that the way that we all function is we have about a 10-degree anterior tibial angle. We don't function with our tibias at 90 degrees of the floor. We function with our tibias at about a 10-degree angle to the floor. And these braces, this bracing method allows for more functional tibial angle to the floor versus the old-fashioned way of bracing. This is actually a kid, believe it or not. He's like 6'3". He's in a stander. We just got him, and you see how happy he is. We like using standers. Of course, standers have some disadvantages. For one thing, you can't mobilize with them, but they do promote orthopedic health, brings a child up to the eye level of their peers. It does help digestion and improves pulmonary hygiene. By the way, anybody know what Civil War general used to believe very faithfully in standing upright because it aided digestion? Stonewall Jackson. Okay, so seating obviously is very important. I'm talking about wheelchairs. It promotes proper posture, reduces primitive reflex and abnormal movement patterns, can normalize tone, and promote normal development. A lot of these kids live in their chairs, so their chairs become cosmetically part of themselves. They almost become like one with their chair. The chairs also, if it's properly made, will help prevent skin breakdown, particularly on the bottom. And lots of kids like to get flames or different colors or designs of their chairs. Now, there's a lot of debate about manual chairs versus motorized chairs, and there's certainly advantages and disadvantages to each. Obviously, if a child can use a manual chair, we want them to because it provides exercise. And of course, you don't have to charge batteries, and they're much lighter and much more portable. But some, especially around here, there's a lot of unlevel surfaces, and it's a lot of work to push a manual chair up a hill. So for that reason and our reasons that a child may not have good enough use of their arms to propel a manual chair, we'll get a motorized mobility. But the problem with that is it's very expensive. We have one child in our clinic whose chair is over $60,000, as an example. Of course, it's a fancy chair. It's got a standard and everything built into it. But chairs are expensive, very expensive, as like any medical device. Some considerations, typically like around 100 degrees of angle between the seat and the back. If the child has a severe deformity of their back, we'll even get custom molded chairs. And we want a chair, if a child has good upper extremity use, we want a chair that doesn't impair their ability to reach around. For example, we put a low back so they can reach back on the floor if they have that kind of skill. Strollers may be okay for children under 3, but it's not appropriate for a child that has the independent ability to mobilize in their environment. Because we want to promote exploration because that's how they learn. Advantages of seating are it's often essential for mobility, and even if not essential, often the preferred mode of locomotion, as I mentioned. Lots of kids can walk, but they can't walk far enough to be functional. It's where the child spends most of their day. And as I mentioned, it promotes normal body position and does offer some flexibility. But they are hugely expensive at times, especially, and they have a limit to their ability of adjustability, how much you can adjust them for growth. It does require a special therapist or a rehabilitation technician who has skills in order to provide the chair, to measure the chair properly, and so forth. And we still have a lot of homes, certainly out where we live, that aren't accessible to chairs. People have many steps to get in their home, or they have small bathrooms. A bathroom needs to have at least a 5-foot turning radius in order to accommodate most wheelchairs. And ramps. Oral medications for spasticity, there are only so many medications that work for spasticity, and it's about 5. I didn't even mention dantrolene here because I don't want you guys using dantrolene for spasticity because it is liver toxic. The most commonly and the safest and the most well-understood drug for spasticity is diazepam. Diazepam is the only drug that naturally comes in a liquid form. If we have to give a child baclofen for some reason, we have to find a compounding pharmacist. And nowadays, there's been a patent restriction put on liquid baclofen, so now we can't even get it for less than $300 a month. But going back to diazepam, as you know, is used for seizures, certainly to stop seizures, and it has been proven to be safe and effective in children. Notice I use very small doses. Especially in a smaller child, I'll start with 0.1 milligram at night, and we'll slowly work our way up to over time before they, till it either becomes effective or till they start developing intolerable side effects like sedation or loss of head and neck control. Baclofen is probably what we use next most commonly. By the way, both diazepam and baclofen work in very similar place in the spinal cord. Baclofen binds presynaptic GABA B receptors, where diazepam binds postsynaptic GABA A receptors. Baclofen typically starts somewhere around 5 milligrams twice a day, and we'll titrate that up to, the book says no more than 80 milligrams a day, but I do in a larger child, like a bigger teenager, I might even go higher than that. Baclofen is actually a pretty safe drug. There has been some recent reports in the literature about baclofen withdrawal. It does seem to be the bigger problem in kids with baclofen pumps. And then Xanaflex or tizanidine is a central acting alpha-2 agonist that can cause sedation, but actually has an added benefit that it helps for pain. So if you have a child who has spasticity and pain, and they seem to be related to each other, Xanaflex or tizanidine actually has a role there. Typically, I'll start 1-2 milligrams at night for children. By the way, the sedating effects of these medications, particularly diazepam, tend to wear off over time. Typically 3 days to 5 days, they'll get better if it's not too bad. I have asked the parents to kind of hang in there. But the anti-spasticity effects of these medications, particularly diazepam, you do not develop tolerance to. Oral medications have many advantages. They're easily adjusted, easily titrated. They're relatively inexpensive in the short run. So it's an excellent adjunct to casting and other things that we do. And they can have multiple effects, calming effects sometimes, and they do work, and they're non-invasive. But they do have multiple side effects, and sedation would be the most common one that we would see. They have sometimes unpredictable results. I mentioned hepatotoxicity mainly for those of you who might use dantrolene. It does require parental compliance, so the parents have to be good. You have to trust them. Back in the days, I think even when Andrea worked with me, we had a mom who was dipping into their kids' Valium. Obviously, not something we were happy about. And most medications are not easily available in a liquid form. BOTOX is something that I was trained in Texas probably since the mid to late 90s. BOTOX was originally invented by a doctor who was an ophthalmologist who was wanting to treat strabismus. So he grew it in his own bathtub and obviously did a very good job because this is really touchy stuff. It's extremely potent, and you have to be very careful with how you dose it. BOTOX works at the neuromuscular junction. It blocks the calcium channels that allow fusion of the acetylcholine vesicles to the presynaptic membrane. It is a permanent effect on that nerve. It kills that nerve. But our body can grow new nerves, or at least new nerve terminals. So that effect takes a while, though. It takes about 8 months for your body to regrow a nerve that's been killed. But about the 3 to 5 month mark, your body grows these little immature synaptic buttons that can actually function temporarily to allow that nerve to re-innervate that muscle. So the effect is clinically about 4 months or so. And so therefore it is relatively long-acting. And we use that period of time to take maximum advantage of stretching and bracing and so forth. BOTOX works very well. It requires a minimum of parental compliance. All you have to do is show up for the procedure. Has almost no side effects, although it does have one side effect of weakness, which is kind of expected because you're blocking your neuromuscular junction. And all things considered, it's a very good therapy for spasticity. Probably not as good as Constraint. It is expensive. It's up, now they're charging about $1,000 for 100 units. It requires multiple injections. The person doing the injections has to have a lot of experience, knows where the muscles are, knows how to figure out. Because some of these muscles are really hard. Can you imagine like the lumbricals? So I have children who have lumbrical contractures, and I've got to inject a lumbrical. It's about the size of a piece of angel hair pasta. And they're right? Of course, we try to sedate them, but that's a tricky thing to do. Also, another really difficult muscle is the tibialis posterior, which sits right behind the tibia, deep in the center of the leg. And the long finger flexors are very deep inside of the arm. And these are, you can imagine children don't care for having big, long needles put into the depths of their arm and their leg. So if a child has many, many muscles, way more than 10 muscles, which, you know, a lot of these kids, it may not be practical because it's a one muscle at a time type therapy. Well, you can do many muscles, but you're injecting, each injection is one muscle at a time. Typically we use Versad, not the anesthesia doses, but anxiolytic doses. And I prefer to do it with EMG guidance. I think, obviously, because I do it this way, this is why that's my favorite way to do it. But there are other people who do it with ultrasound guidance. The best part about EMG guidance is that there's only two tissues in the body that generate electricity, muscles and nerves. And so if I'm not hearing that really crisp sound, I know I'm not in a muscle. Sometimes I can be between muscles. Sometimes I can be in a, hopefully not, in a vessel. Obviously, that's the worst case scenario. We try to stay away from those. So we aspirate to prevent that from happening. But with EMG guidance, I can be, and with joint maneuvers and with the help of the therapist, I can be pretty doggone sure I'm in the right muscle. Intrathecal pumps, we do. I don't like to use them in children who live out in the woods. Like a lot of my kids come from West Virginia, southern West Virginia, and out western Virginia. And baclofen pumps scare me a little bit because if a pump is going to fail, it's going to stop providing baclofen. So basically what you're doing, if the pump fails, you're putting a kid through baclofen withdrawal. And then you have to have an emergency room in your area that has the ability to interrogate the pump to see what's going on. And those things just aren't available. I think we have one in the New River Valley. Most of the emergency rooms here in Roanoke do have pump wands or readers. I've actually got one, but it's out of date. So intrathecal pumps, we typically will use them in children who have bad spasticity, global spasticity, but cannot take enough of the oral medications to actually provide benefit before they start having severe side effects. So the pump has a place. Another problem with pumps, too, is that a lot of these kids don't have a lot of real estate. You know, these are skinny kids sometimes, many times, and the pump actually can protrude from their body and create an area where they could either get caught on something or they can get skin breakdown. So I don't routinely refer kids for pumps. If I'm referring a kid for a pump, it's usually a pretty dire situation where nothing else has worked very well and they're having severe problems. So the advantages of intrathecal pumps is they do have less systemic side effects and can be titrated to higher effects. There is still a low plasma level in the body of the medicine. Typically it is baclofen we're using. Compliance is usually not as much of an issue. You got to show up for your pump refills. And there is a pretty good success rate for pumps when they are used, but they're expensive. They're probably around $40,000 start to finish to put in a pump, and then you have to have refills depending on how often you need a refill. It depends on how much baclofen you're using. It can be as often as every 3 weeks. You can get kinking of the catheter. The batteries now are lasting closer to lifetimes, but if you do have a battery failure, you have to take it out. There is a small infection risk. After all, this thing is applied into your central nervous system, and it can cause weakness. I think they're overutilized. Selective dorsal rhizotomy is still being done. In fact, there's several centers. I believe UVA and Richmond both do them. St. Louis is kind of well known for their selective dorsal rhizotomy program. And this is a neurosurgical procedure where they open up the spinal column and they stimulate the rootlets. Now, there's about 6 rootlets per level in your spine. So the surgeon will apply electric current to one of the rootlets, and if it induces a spasm, particularly if there's distant effects, like if they're stimulating a rootlet to the legs and the arm has a spasm, then they know that rootlet needs to go, so they cut it. And then they go to the next rootlet. And if they do the same thing, and if they get spasm with stimulation of the sensory rootlet, they cut that one too. And then they typically will stop then when they get to the point when no longer are they inducing a spasm. This is really quite an effective way to reduce spasticity. It has certainly a place, and it's still being done, but it can actually worsen scoliosis. So they do last at least 5 years, and they're relatively specific. There's no minimal compliance issues, and it does help with hip stability, and it does appear to have positive suprasegmental effects. So, for example, children who have spasticity in their legs more than their arms, they do a dorsal rhizotomy, they'll actually have decreased spasticity even in their arms. Kind of weird, huh? But the spinal cord is an amazing thing. It's not just a nerve, obviously. It's an extremely complex neural processing center. And spasticity is basically run by the spinal cord. The brain's job primarily is to inhibit the spinal cord. So that's where spasticity comes from, as we believe, is that when the brain's not inhibiting the spinal cord enough, the spinal cord takes over, and that's where spasms come from. It is an ablative procedure. Obviously, ablative procedures are not something that I see us as a human population doing forever. And if it gets down to lower levels, it can disturb bladder function, and as I mentioned, it can lose effectiveness over time. And the big kahuna, orthopedic surgery. This is, surgeons, I guess, are like doctors, like police, like firemen. You don't ever want to have to see one. But when you really need one, oh, by golly, you need them right now, right? Surgery can do things that nobody else can do. Obviously, it takes a lot of skill to become an orthopedic surgeon, and there are just not a whole lot of pediatric orthopedists around. It is a definitive thing to do. It's a permanent thing to do, and sometimes it's the only thing that works. If you have a joint contracture that's gotten into the joint capsule, that is something that only surgery can fix. It is permanent, requires a lot of training, and typically we would prefer, if we could, to get a gait analysis done before they have it done. Unfortunately, we don't have one here. We do actually have one at Virginia Tech, and I have called and bugged those people, and they will not let me send any of my patients over there. It's only for research. So in summary, most modalities work best when done in concert with others, particularly therapy and bracing. We focus on function. We definitely need the team. The team approach works best, and parents are part of that team. All right, we have time for the quiz. You guys ready? You been paying attention? 3-year-old child from a country at war had no perinatal or postnatal care, is awake and alert, but has definite writhing movements which appear to be involuntary, and he is severely developmentally disabled. The next most important task to perform. Take a shot. This is the hardest one, so. And then you got to tell me why. Anybody want to take a shot at it? Response to a ringing bell. So why? It turned out this child could not hear the bell. Now, brainstem evoked potentials would be right along the line. I probably got an MRI brain and EEG, so these are all decent answers. But the next best thing to do would be to see if they can hear. Of course, I asked Mom, can he hear? She said, I don't think he can hear. Well, he was in Iraq right when this war started. He had no perinatal or postnatal care. He was severely jaundiced, and he wasn't treated for it because they couldn't get out in the sunlight. There's nothing they could do. They had to stay away from the bombs. So he developed kernicterus. And what does kernicterus do? Kills your ears and your basal ganglia. So you get apoptotic movements and hearing loss. That's the hardest one. What is the single most common reason why a child with cerebral palsy would worsen with respect to range of motion in their feet and knees? Come on. That's a good answer, but there's a better one. These are all good answers, by the way. That's why distractors are good, right? Because they both growth. Bones grow faster than muscles. If you don't treat spasticity, if you don't treat range of motion problems and the kid grows, it gets worse. So it's a constant battle, dealing with growth. Failure stretch is also very important, and I don't want to belittle that answer because that's actually very close to being the right answer, just not quite as good as growth. Well, plus, notice the word the most common reason. Everybody grows, right? The most common side effect of BOTOX injections. Weakness, right? These are all reported possible side effects for BOTOX. The encephalopathy thing has never been proven. That was more in the legal world. There was a guy out in Richmond area who was blaming BOTOX for an encephalopathy. Never got proven. Definitely causes dysphagia, though, if you get it around the neck and dry mouth. But weakness, everybody gets a little bit of it. What is one of the most common causes of disability, but the most difficult to quantitatively assess? Sensation. Remember I mentioned before how important sensation is, especially for balance, head and neck control. You have to be able to feel to do anything. And it's very difficult to assess it. Other than two-point discrimination, there really isn't much quantitative ways to measure sensation. Of the sensory modalities, which one is the most important for function? Proprioception. Good. All right. You guys get A's. I don't think you can read this or not. Some more. I have actually some paper articles up here in front of you guys are interested. If you ever want to get, by the way, I was going to put my cell phone here, and I'm willing to give it to you now, but I heard that these talks actually go on the internet, and nor I wanted our personal cells on the internet. My personal cell is 540-230-1022. I encourage any of you to call me at any time. Any questions?
Clapping? All right, here we go.
Sorry, I get such mad.
Thank you so much for really wonderful grand rounds. I do have a question about the restraint therapy and then...
Constraint, yeah.
Excuse me,
No
yes,
problem.
constraint therapy. And the long-term data for success, because the graph that you showed looked like it was fairly short-term data.
Right.
And then if they make the gains, how long do those gains actually last over years?
Unfortunately, we don't have long-term data on constraint therapy because we've only been doing it since really 2007. so we don't have a lot of good long-term data. It appears to be extremely effective and does have a lot of permanence to it. But I don't think I can answer that question for super long-term data because it's just not been done that long.
So my question is related to BOTOX injections. Is there like a law of diminishing returns on those that over time they work less and less? And also, the second question, kind of related to the first, is at least in esophageal BOTOX injections over time, there's some fibrotic change that develops, and is that something that you see also in skeletal muscles?
BOTOX actually seems to get more effective up to about the third time you do it. And then, yes, there are certainly kids where it becomes less effective, but I don't know if it's because that it's not working as well. I worry that it's because there's other things going on, like joint contractures are starting to, our bony deformity, and those are things that BOTOX can't fix. It only works for spastic muscles. So I would say that yes and no to the first part. It seems to work better the first couple of times and then maybe tails off over time after that, but not necessarily because it's not working, but because the process has changed. As far as fibrosis, haven't seen that, but that would be something that would be worth studying, yes. Dr. Tomas.
For some of the children that I see who have generalized spasticity, through the years, and particularly as they go through their teen years, it seems that changes. I've seen some of them worsen, particularly with their spasticity.
Right.
Have you seen that, and do you have any understanding of why that is?
Yes. Well, certainly growth. They'll lose range of motion with growth, as I mentioned before, because the bone is growing faster than the muscles. As they get older, they get more deformity. That can worsen spasticity. They get more problems with constipation, for example. That can worsen spasticity and other medical comorbidities. It is a big problem. I'm not sure I answered your question. Yeah, okay. Yeah.
Okay. Any other questions or comments in the room? Nope. All right.
Can you just describe one last time the classification again of spasticity from like 1 to 1 plus 2, and then I guess almost to rigid? Just to make sure, like, if I'm to use the right words when I'm describing something.
Okay, well, there's different. There are several different scales that are used. The Ashworth scale is the one I use the most, and it relates to, so a 4 would be rigid in space. A 3 would be able to range, but very difficult. A 2 would be able to get full range with relative ease, and then a 1 would be just a little bit of noticeable catch. But there's also other scales. There's a 10 scale, which refers to how many spasms per hour. I never use that. Most people I know that most people in rehab medicine use the Ashworth scale.
Any other questions in the room? All right, I think we are right at time, and I'm standing under the speaker. We are right at time, so thank you very much.
Thank you.
On the line. We apologize we did not have time to unmute the phones, but you can always email us at outreach@carillionclinic.org, and I will get them to our presenter. So with that, we're going to disconnect the phone lines now. Thank you all very much for joining us.